Study comparison on repetitive concussions, post-SCAT-5 symptom score clearance in a Division II baseball player. Investigator Matthew Gallagher and co-investigator Dr. James Robinson. This case study will review the comparison of the Sports Concussion Assessment Tool, SCAT-5 if so, systematic score results from an athlete that received a concussion from a baseball while sliding into base. The athlete completed a thorough post-concussion protocol and was going through the first full day of activity and received a concussion in the same format as before. The comparison is to find, if any, the difference or similarities between the concussion SCAT-5 results. There is a significant relationship between the athlete and a repeated concussion on the final day of post-concussion protocol that leads to risk of second impact syndrome. Or there is no significant relationship between the athletes and a repeated concussion on the final day of post-concussion protocol that leads to risk of second impact syndrome. Many individuals have sustained a head injury which resulted in a concussion, and after a few weeks the symptoms subsided with no long-term health effects. However, many athletes are susceptible to multiple head injuries. Concussion symptoms can have lingering effects that could be compounded if the athlete sustained another head injury during the recovery process. This phenomenon is referred to as second impact syndrome and may have serious long-term effects on the individual. This study will track the symptoms of a collegiate baseball player who received 2 concussions and determine when the symptoms were at their highest and when symptoms decline. This type of individual assessment can help determine when it is appropriate for the athlete to return to contact. The severity of concussion injury has a possible correlation to post-concussions, second impact syndrome, or the possibility of death. First, it is important to discuss concussions in athletics and how they correspond to research, concussion assessment tools, and proper treatment and rehabilitation needed for recovery. Second, the literature will discuss post-concussion symptoms, what results can come from post-concussion testing, and how severe post-concussions cause delayed or prolonged recovery. Finally, the literature will explain how second impact syndrome can occur in athletics, how to prevent second impact syndrome, and all correlation and chances of death from concussions. Gesell stated that concussions represented 8.9% of all high school athletic injuries and 5.8% of all collegiate athletic injuries. In all sports, collegiate athletes had higher rates of concussions than high school athletes, but concussions represented a greater proportion of all injuries among high school athletes. Athletes with multiple concussions are 7.7 times more likely to demonstrate a major drop in memory performance than athletes with no previous concussions. Iverson in 2009. Boys sports accounted for 53% of all athletes' exposures and 70% of all concussions. The University of North Carolina recruited 271 intercollegiate athletes and completed a comprehensive baseline concussion battery. After completion, the group scapped 5 symptoms into 4 symptoms cluster severity scores, starting with cognitive sensory, sleep arousal, vestibular somatic, and affective, which served as the independent variable. The patient-reported outcome measurement information system, subjection scores of anxieties, depression, fatigue, pain interferences, pain intensity, physical function, sleep disturbances, social roles, fatigue, cognitive function, and the neurological disorder scale, subsets of fatigue and cognitive function served as a dependent variable. The tested method was a multiple linear regression for each of the health-related quality of life subjection scores using the symptoms cluster severity scores as the predictor variables. Participants reported the following cognitive sensory clusters, most often as 68.6%, affective at 38.2, sleep arousal at 32.9, and vestibular somatic at 31.1. Higher cognitive sensory and affective symptom cluster severity scores were associated with worse cognitive function. The study was completed on post-concussion assessments. The post-concussion assessments were administered to 75 athletes within 24 hours of a physician-diagnosed concussion. Individual tests and the complete battery were evaluated for sensitivity to concussions. The computerized immediate post-concussion assessment and cognitive testing and Heed-Minder Concussion Resolution Index, a neurocognitive test. The study also included the evaluations of self-reported systems, postural control evaluation, and assessment of neurocognitive function. The study showed that the impact is 79.2 sensitive to the effects of concussion, and HeatMinder CRIs is 78.6% sensitive. The other evaluation methods were less sensitive, with self-reporting being the highest at 68%, and the neurocognitive assessment being the lowest at 43.5%. When the complete battery was assessed, sensitivity exceeded 90%. These findings support previous recommendations that sports-related concussions should be approached through a multifaceted assessment with components focusing on distinct aspects of athletes' function. SCAT-5. Clinically, the summary score is intended to measure changes in global functioning across baseline, post-trauma, and follow-up concussion evaluation. Additionally, it should serve as a measure of global progression during the acute post-trauma window of sideline to post-trauma evaluation. SCAT-5 is a standardized assessment tool for evaluating concussions that includes an immediate on-field assessment and off-field assessment. The results are compared to either the athlete's baseline assessment or using normative scoring. Hanianen conducted a study that examined the short-term test-retest reliability of the SCAT-5. The study concluded 62 hockey players who completed the baseline test over a 2-week interval. The baseline assessment showed over half of the players reported at least one baseline symptom, with the most common being fatigue and neck pain. Hanian concluded that 2-week tests and retest reliability of the SCAT-5 baseline scores varied from moderate to high. However, there was considerable individual variability on the standardized assessment of concussion and modifications balance error scoring system scores. Most players have notable short-term fluctuation on performance even if uninjured. Future research should be examined the SCAT-5 summary score with an outcome measures such as recovery time. A positive concussion diagnosis, the patient should be immediately removed from the further participation for at least 24 hours. Following up testing using the same protocol as a baseline examination can be aid in determining when to start the return to physical activity after a patient is cleared by a physician or designate. Lastly, although most concussions resolve in a relatively short frame, patients who are young, who have had multiple concussions, who have morbid factors may require additional attention. The athletic trainer should be familiar with the concerns as well as the potential for long-term concussions and account for them in concussion management planning. Current literature suggests that there are different symptoms factors at baseline, post-injury, and along with several age and sex differences. Post-injury symptoms fall into global concussion factor, which includes cognitive, fatigue, and migraine symptoms. Reported baseline symptoms are not the same post-injury. Global post-concussion symptoms, including fatigue, factor highlights the importance of physical and cognitive rest during the first week after a concussion. Research conducted by Askin reviewed 97 athletes who sustained a concussion between 2008 and 2015. The injured athletes were placed into two groups: immediate removal from activity, or IRFA, or delayed removal activity, DRFA. The main goal was determining how many days missed the athletes received. Days missed and understood to be number of days between the concussion and the clearance to return to contact. Just over half the athletes did not immediately self-report concussion symptoms when recognized. The DRFA group averaged 4.9 more days missed than the IRFA group. These results suggested that the DRFA group were 2.2 times more likely to experience recovery of more than 8 days compared to the other group. Continuing to participate in athletic activity during the immediate aftermath of a concussion potentially exposes the already injured brain to compounded neurophysiological processes. Second impact syndrome may occur with any two events involving head trauma, involving showing post-concussion symptoms, and within a few weeks the athlete sustains another head injury. While rare, it is devastating in that young, healthy patients may die within a few minutes. Emergency physicians must be aware of SIS syndrome and counsel both patients and parents on the concerns if the athlete returns to play too soon. Herbert reviewed 338 articles. However, only 8 articles were relevant for the evaluation. The lack of the relevant articles reduced the significance and confirmed signs of symptoms were either mixed or absent. However, information did exist to support a possible high-risk population signs and symptoms. Further research needs to be conducted to better understanding and define the components of the patient's pathophysiological magnetic re- uh, resonance imaging, biological markers, and behavioral indicators in regard of SIS. Catastrophic brain injury prevention in sports must be a top priority of researchers and must involve prevention and education about traumatic brain injury, enforcing the standard use of sport specific and certified equipment, use of comprehensive baselines and post injury assessments, home care, and referral instructions focusing on monitoring and management, use of systemic review of return to play considerations, clear documentation to guide a sound return to play decision, and proper preparedness for an on-field medical management. This research project will be conducted by reviewing and comparing two post-concussion protocols. In the protocols, there will be a SCAT-5 document that has a system score test, which will ask for numeric scores of possible symptoms that concussions may be causing and are done each day after the concussion. Each day's scores will be separated by first concussion and second concussion, then compared and implemented into an Excel document. The tables of both concussions will be color coordinated by level of severity to describe a better description of the fluctuation of the concussions. The total amount of symptoms by days and symptom severity were compared and graphed in search for any findings that may have led to risk of second impact syndrome. The first concussion totaled 19 days, with only 12 of those days showing symptoms. The first week of the concussion showed the highest amount of symptoms and total symptom severity. The leading symptoms causing severity to the athlete were difficulty concentrating, pressure in head, headache, trouble falling asleep, and don't feel right. The second concussion totaled to 12 days, with only 5 of those days having symptoms, the highest number of symptoms and severity being day 1 and 2, with the worst symptoms being pressure in head, blurred vision, feeling like in a fog, and difficulty concentrating. The first and second concussion total number of symptoms and symptom severity score were graphed by day to look for major fluctuation which may have gave way to higher risk of further injury. Looking at Table 3, comparison of total number of symptoms, we have the first concussion in dark red and the second concussion in orange. We see a major spike for the first concussion on day 3, going from 17 to 16 to 21, which is a 5-point gap from the second day. Another interesting thing about the first concussion is the rise and fall to the slow descent to symptomatic zero or symptom free. Looking at the second concussion, we have a decent fall over the first 4 days of symptoms with a random spike in the 5th day, unknown cause, with an instant drop in severity on the 6th day. So it could have. Looking at Table 4, the comparison of symptom severity scores, again with dark red being the first concussion and orange being the second, we can see that the first concussion has a small peak till day 3 with a symptom score of 64, which leads down to day 5 where it bottoms out at 52 with an increased spike back up to 60 that matches day 4's symptom severity score, with a major drop by day 7 to only 32 with a normal shallow decrease into symptom severity score of 0. Going back to concussion 2, though, we again see a nice slow decrease through days 1 through 4 in symptom severity with an increased spike on the 5th day. Comparison of the concussions show that the first concussions lead in total number of symptoms and symptom severity, including day 3, indicates the most at risk of further injury, leading with 21 out of 22 symptoms and a severity of 65 out of 132. If an athlete were to suffer a secondary concussion on a day with similar scores, they could possibly be at risk of second impact syndrome, with fluctuation throughout the first concussion. Day 6 presents a potential spike in severity with a normal fall in total number of symptoms. The following day led with a reasonable fall in symptom severity and total number of symptoms. This fluctuation would have been of high concern, and day 7 were to rise rather than day 6 and continue to rise over the following days, and or if the day 8 were to have had any major rises or falls in symptom severity. The second concussion showed minimal scores compared to the first concussion, with only a spike in both total number of symptoms and symptom severity on day 5. The spike only reached 5 out of 22 symptoms and 5 out of 132 in severity. This spike showed no risk for further injury. The only symptoms that are causing the most severity in both concussions were pressure in head and difficulty concentrating. These symptoms can be caused by more severe injuries that can occur from contact concussions. Questions derived or reviewing the results were from the need of more documented cases of possible second impact syndrome. Some of the questions were: was this a normal second concussion? Is there a corresponding rise in certain symptoms in other second impact patients? And if so, why? Is there a certain number of days that are high risk, and what days are they numerically? Can you even compare concussions, even if caused by the exact same measures? In conclusion, there is no significant relationship between athletes and as repeated concussions on the final days of post-concussion protocol that leads to risk of secondary impact syndrome, which supports the null hypothesis. The analysis suggested only minor increases in symptoms and severity if the second concussion occurred within the first few days. First concussion, perhaps the athlete would have been more at risk for second impact syndrome. For better results, an increase in documentation of patients that were possibly at risk of second impact syndrome could show more results that could be compared to find symptoms that are possible more susceptible to leading to patient to second impact syndrome, or possible amounts of days that they are at risk and when they are not. Thank you.